Bare lymphocyte syndrome (BLS) is an immunodeficiency disorder. Look at this picture shows that skin infection due to immunodeficiency and disease mechanisms. Look at this. Detail going on. Introduction. Bare lymphocyte syndrome is a rare and severe primary immunodeficiency disorder characterized by the absence or malfunction of major histocompatibility complex (MHC) molecules on the surface of antigen presenting cells (APC). This deficiency hampers the immune system's ability to recognize and respond to foreign pathogens, leading to recurrent life threatening infections. BLS typically manifest early in life and requires prompt medical intervention. Definition: Bare lymphocyte syndrome is a group of hereditary immunodeficiency disorder resulting from defective expression of MHC class 1 or 2 molecules on the surface of the lymphocytes and other antigen presenting cells. This leads to impaired immune responses and increased susceptibility to infections. Etymology: the term bare lymphocyte syndrome originates from the observation that lymphocytes in affected individuals lack or bare of especially surface molecules, specifically MHC class 1 or 2 proteins. Word lymphocyte comes from the Latin lympha, meaning water, and the Greek kaitos, meaning cell, referring to white blood cells involved in immune response. Epidemiology: Bare lymphocyte syndrome is a extremely rare primary immunodeficiency disorder with an estimated incidence of less than 1 in 1,000 live births worldwide. It is more commonly reported in populations with high rates of consanguineous marriages, such as in parts of the Middle East and North Africa. Types. BLS is categorized into two major types. One, type 1, MHC class 1 deficiency, caused by mutations affecting the transport and expression of MHC class 1 molecules. Less severe than type 2. Affects mainly CD8 plus T cell function. 2. Type 2 MHC class 2 deficiency, more severe form, caused by mutations in transcription factors that regulate MHC class 2 expression. After CD4 plus T cell development and function, often fatal without treatment. 3. Type 3 combined MHC1 and 2 deficiency, extremely rare, defects in a shared pathway affecting both MHC class 1 and 2 expression. Causes: genetic mutations inherited in an autosomal recessive manner. 1. Type 1 mutations in genes like TAP1, TAP2, TAPBP. 2. Type 2 mutations in CIITA, RFX, ANK, RFX5, RFX AP. Risk factors: 1. Family history of primary immunodeficiencies. 2. Consanguineous marriages increase the risk due to autosomal recessive inheritance. 3. Certain ethnic groups with higher consanguinity rates may show increased incidence. Complications: 1. Chronic and recurrent infections, bacterial, viral, fungal. 2. Failure to thrive in children. 3. Chronic diarrhea and malabsorption. 4. Respiratory failure due to repeated lung infections. 5. Death if untreated, especially in type 2. 6. Autoimmune diseases may develop in some cases. Pathophysiology. Pathophysiology of bare lymphocyte syndrome, step by step process. The pathophysiology differs slightly between type 1 and type 2, but both involve impaired antigen presentation and T cell dysfunction. Below is a general step-by-step breakdown with distinctions where necessary. Step 1, genetic mutation cause autosomal recessive mutations in genes responsible for the expression of MHC molecules. Type 1 mutation in TAP1, TAP2 or TAPBP genes. Type 2 mutation in CIITA, RFXS, RFXAP genes. Step 2, a defective MHC molecule expression. Type 1 TAP proteins fail to transport peptides into the endoplasmic reticulum, preventing proper MHC class 1 assembly and surface expression. Type 2 mutation transcription factors prevent MHC class 2 gene expression entirely. Step 3, impaired antigen presentation. Type 1 MHC class 1 molecules cannot present viral intracellular antigens to CD8 plus. Cytotoxic T cells. Type 2 MHC class 2 molecules cannot present extracellular antigens to CD4 plus helper T cells. Step 4, abnormal T cell development. Type 1, defective CD8 plus T cell function and reduced numbers in the periphery. Type 2, CD4 plus T cell development in the thymus is impaired, leading to severe CD4 plus T cell deficiency. Step 5, immune system dysfunction. Type 1 weakened cellular immunity against viruses and intracellular pathogens. Type 2 severe combined immunodeficiency affecting both cell mediated and humoral immunity. Due to poor B cell activation and antibody production. Step 6, clinical manifestations, recurrent infections due to compromised immune defense. growth failure, chronic diarrhea, respiratory issues, and life-threatening complications. This step-by-step pathophysiology process highlights how the absence or malfunction of MHC molecules leads to profound immunodeficiency in BLS. Signs and symptoms: 1. Recurrent upper and lower respiratory tract infections. 2. Persistent diarrhea. 3. Failure to thrive or developmental delays in infants. 4. Skin infections, abscesses. 5. Enlarged lymph nodes and spleen. 6. Delayed wound healing. 7. Oral thrush and chronic candidiasis. 8. Chronic fatigue and weakness. A diagnosis: 1. Clinical evaluation, history of recurrent infections, failure to thrive. 2. Laboratory test, lymphocyte subset analysis, low CD4 plus or CD8 plus T cells, immunoglobulin levels, flow cytometry or MHC molecule expression. 3. Molecular genetic testing, identification of mutations in genes responsible for MHC expression. 4. Biopsy or histopathology may show absence of MHC molecules in lymphoid tissue. Nursing diagnosis: 1. Risk for infection related to impaired immune response. 2. Imbalanced nutrition less than body requirements related to chronic illness. 3. Ineffective breathing patterns related to recurrent respiratory infections. 4. Fatigue related to chronic illness and poor oxygenation. 5. Anxiety related to prognosis and chronic disease management. Medical management first. 1. Antibiotics, antivirals, antifungals for treating and preventing infections. 2. Immunoglobulin replacement therapy provides passive immunity. 3. Hematopoietic stem cell transplantation HSCT. Curative in type 2 BLS. 4. Gene therapy, experimental, future potential treatment. 5. Supportive care, nutritional support, hydration, oxygen therapy. Nursing management. 1. Monitor vital signs and signs of infection. 2. Administer medications as prescribed, antibiotics, IVIG. 3. Maintain strict aseptic techniques. 4. Educate family about infection control at home. 5. Provide emotional support and counseling. 6. Monitor growth and development in children. 7. Coordinate care with multidisciplinary team, immunologist, geneticists, dietitian. Treatment options. 1. Stem cell transplantation, especially in BLS type 2, offer a potential cure. 2. Prophylactic antibiotics or antivirals prevent opportunistic infections. 3. IVIG therapy, monthly infusions to boost immunity. 4. Nutritional therapy to support growth and immunity. 5. Experimental gene therapy under research for correcting gene defects. Psychosocial medicine. 1. Family counseling to manage emotional stress and plan for care. 2. Support groups for families and parents dealing with chronic immunodeficiency. 3. Education programs on infection control, hygiene, and home care. 5. School support services for children with frequent absences due to illness. 5. Psychological therapy to manage anxiety, depression, and adjustment disorders in long term care settings. Prevention. 1. Genetic counseling for at risk families. 2. Carrier screening in consanguineous marriages. 3. Prenatal diagnosis via chronic villus sampling or amniocentesis if family history is known. 3. Avoid exposure to infectious agents in known cases. 4. No vaccine preventable strategy due to genetic basis, but infection prevention is critical. In conclusion, bare lymphocyte syndrome is a life threatening primary immunodeficiency resulting from the absence of MHC class 1 or 2 expression. It manifests in infancy with recurrent infections and failure to thrive. Early diagnosis and aggressive management, especially stem cell transplantation in type 2, are essential for survival. Psychosocial support for the patient and family combined with preventive genetic counseling can greatly improve quality of life and outcomes. Continued research into gene therapy offers hope for future curative options. Thank you. Have a nice day.